The reality of rural healthcare is millions of Americans aren't able to walk into a Harvard quality care. The standard of care at Mass General on a given day will never be comparable to triaging 160 migrants in the dark of the night in Antelope Wells. Dr. Mitchell's testimony is balanced and professional. It's not political hyperbole, but it does suggest that the federal government has the ability to deploy doctors to remote areas of the border to interview migrants about their health and do a variety of tests, which is simply unrealistic. Dr. Danaher's written testimony is blatantly partisan. She critiques the conditions of CBP facilities going on about lack of toothbrushes and clean water. I know from my own visits to CBP facilities and the facts in these cases, those allegations are simply false. She also discusses the psychological dynamic of the dad of one patient to not share information to agents as if that environment is the law enforcement officer's fault. That dynamic existed because he crossed the border illegally and then didn't tell agents that Jacqueline was sick, even when they repeatedly asked him. If a patient presents to an ED in the United States and lies about their medical condition, it's not the doctor's fault. Look, both of your testimonies center around getting more resources. The bottom line, you want more doctors and electronic medical records. Just published yesterday, new estimates of doctor shortages in the U.S. The U.S. is short 14,494 doctors. Where in the world are we going to get doctors to put somebody at every single crossing site? This testimony proposes building healthcare infrastructure for illegal immigrants that would dwarf the healthcare systems in 77% of rural counties in America. Last year, House Democrats voted to advance an electronic medical record to illegal immigrants within 90 days when veterans in many states still don't have it and won't have it for 7 years. Finally, this side of the aisle spent all of last year highlighting how dangerous the journey to our border is for kids. The answer is not to turn CBP stations into Mass General. We have to break the cartels that entice people to come here with children and fix our immigration law loopholes. Until we do that, smugglers will continue to turn a profit over enticing families to come to our border with false promises. Mr. Chairman, I yield.
Thank you, Mr. Chairman. Dr. Mitchell, you mentioned in your testimony that resource hurdles prolong CBP custody and delay access to medical care. I agree. The efforts led by House Democrats to defund ICE have had sweeping consequences, mainly impacting CBP facilities, such as what happened during December of 2018. ICE family residential centers were at capacity, forcing CBP to hold immigrants much longer than they should. The bureaucracy exasperated by the border crisis, preventing those CBP custody from reaching ICE facilities built for long-term holding and for more through medical assessments and access to care. My question to you is, do you support additional funding for ICE capacity and medical staff to ensure that children don't get stuck in CBP custody like they did last year?
Yeah, I think that any funding that's going to go forward to resolve this issue must go forward to decrease any overcrowding burden. I'll leave it up to the House and the politicians to understand where exactly that goes and what the agencies use, what agencies get those resources. But I think you and I agree, Dr. Green, that overcrowding conditions is a major concern, particularly when we're talking about infectious disease. And then as far as the issue of timeliness, and I appreciate you elucidating the fact that I wanted better access to healthcare there at the border. I agree. I think physicians would be a hard burden, a hard bar to reach. But I believe that there's opportunities, as my colleague Danaher described, is that higher training of the EMT, maybe nurses, nurse practitioners that are available there to make sure that the burden is not placed on our agents to try to triage these patients.
I really appreciate your comments, and I think clearly we on our side of the aisle would like to see more funding for ICE. There are a lot of people, especially for those detention facilities, a lot of people on the other side of the aisle want to defund ICE. But I want to follow up one more question, Dr. Mitchell, for you before my time expires. You indicated in your testimony that you believe Jacqueline's death could have been prevented in the initial health assessment questionnaire if it had been performed by a licensed medical provider. You you may not know this, but yesterday, DHS, or not DHS, but HHS released the doc shortage. 77% of America's rural counties right now are short both doctors and PAs. And by 2032, that's going to be 121,000 short. Where do we get these medical providers? I mean, would we take them from American cities? I'm eager to hear your thoughts on that.
No, and again, I think the shortage of medical providers is across the nation, as you described. I just don't believe that the recommendation that of providing adequate health screening to whoever we come into contact with, it stops being a recommendation because the hurdles and barriers are too big. I think our job is to try to create opportunities where we can meet the goal of saving lives wherever it exists. And so, no, not take it away from anyone, but attempt to provide it to everyone.
Yeah, we just have to be realistic in our solutions and find solutions that work. And your recommendations were, a licensed medical person. And with the shortage we already have, I just don't see how that can happen. I think my time has expired, Mr. Chairman. A very quick question to Dr. Danaher. Have you done med mal cases, review cases before?
No.
You obviously reviewed the records here. What stood out to you about the resuscitation in this case of Felipe's resuscitation when you reviewed that case?
In terms of when he presented to the hospital the second time?
The second visit, when they tried to resuscitate him, was there anything that jumped out to you as a physician on that resuscitation documentation?
There were definitely some irregularities in terms of what happened when he reached the hospital. But he arrived already pulseless. They had a really difficult time intubating him. There was a significant amount of blood in the airway, so they had multiple failed intubation attempts, including an esophageal intubation.
If I could just answer the question, because I know you've played, guess what I'm trying to ask you before as a physician. We do that a lot to one another. But he was incorrectly intubated, and they continued the resuscitation for several minutes with the breathing tube down his esophagus. Clearly, that you can't resuscitate a patient, and he's not getting oxygen for several minutes in the resuscitation. That's problematic for saving the child's life. I yield. Thank you, Mr. Chairman. And I just want to say, we are responsible. I can tell you, I will never forget the first child that I had to pronounce. The child had been hit by a car, and the image of that mother bringing that child in her arms is forever burned in my brain. The loss of these two children, it is tragic, but what we're doing here is a forensic examination of the record to find where fault happened. This is designed to find where there is fault. And so it takes an objective setting that aside and looking at the case. And so I want to ask Dr. Danaher again, the records are pretty clear that the father of young Jakelin was asking for medications from his fellow travelers before entering into the United States. In fact, since the antibiotic he had on his hands was Flagyl, not the best for strep infection, they probably didn't get that prescribed by a physician. He knew she was sick and he failed to disclose it. You mentioned in your written testimony about the environment of a person answering questions to law enforcement being a barrier for Jakelin's father telling the truth about his daughter being sick. And I want to ask you, are you suggesting that there's some kind of new standard of care that if a patient lies about their medical condition, the physician or that provider is somehow liable?
Not at all. What I'm saying is that the initial screening that occurred when this large group of migrants arrived at the forward operating base was, from what I can gather, one agent yelling to more than 100 people that if anybody was sick, they should come forward. They yelled this in Spanish. The father's native language is Kepchi. And so we don't know if he heard them. We don't know if he understood them. On top of that, we're asking people to come forward in front of a large group of people to talk about their medical issues, which, as I'm sure you appreciate, can be very sensitive for some.
Yeah, but you have children yourself?
I do.
So can you imagine having a sick child and not wanting them to know about it? I mean, I don't understand that dynamic.
I'm not
Those
sure.
parents, I've taken care of a lot of pediatric patients in the ER, and those parents are afraid. They come in and they want to tell you, and why would he? I don't understand why a father who cares about a child would specifically lie when asked. And they asked in Spanish, and he responded in Spanish, so he clearly understood Spanish.
So I think that there is a difference between being able to speak a little bit of Spanish versus to share sensitive or nuanced medical information in Spanish. On top of that, the questions on the health interview form are very non-specific. There's one question about any type of illness, and the rest are about things that wouldn't be particularly relevant to Jacqueline's case. So this all hinges on whether the father understood that one question.
I don't agree. I don't disagree with you that a form review could make that form better. I can't make CBP responsible for a guy who says his children are okay when asked if they're medically ill. Let's flip to Felipe's case, and I only have a little bit of time, so I'm going to get right to it. You made some very, I think, appropriate comments in your written testimony about his first visit. When he went in, and I mean, it was horrible when I looked at it, but I want you to tell the committee what you thought about his care when he was first brought to the hospital there at GCRMC, and whether you think they should have let that patient go home.
No, they absolutely should not have let him go home. And I agree with you that the care that he received was very concerning during his first presentation. His vital signs were significantly abnormal. His heart rate was persistently elevated even when he did not have a fever. His oxygen level went as low as 91% at one point. It's not clear that anybody noted that fact. The physician who saw him later acknowledged during a CMS review that he had not reassessed Felipe before the child left the facility.
Yeah, and I didn't see any assessments for hydration status, tears or voice mucous membranes. I mean, all those things would be standard of care. This is an American physician in an American emergency department, and they let this kid go home. My question is, would a normal law enforcement officer question a physician like that? Is he trained enough to question the physician?
Well, what's interesting in this case is that it appears that the law enforcement officer did. He actually advocated for Felipe to receive more care before they left, and continued to express concern after they left, which says to me that they could recognize that he was quite sick.
Yeah, they definitely recognized that the care given was pretty shoddy. I mean, I think he had to ask to have the temperature taken. So thank you. I yield, Mr. Chairman. Thank you, Mr. Chairman. I want to first thank Congresswoman Slotkin for her questioning. I thought I echo everything she said and agree with her 100%, and look forward to hearing back from the department on those misfit funds. That really is one of our primary concerns. I also want to appreciate the fact that Congresswoman Rice recognized and reiterated the need for America to address this physician shortage. We have significant physician shortages now, and it's only going to get worse in the coming years. My point in bringing it all up is that we had testimony from witnesses who said we needed licensed professionals. My conclusion from all this is we can't take those people where Americans aren't even getting care and put them on the border. What we really need to do is give advanced training to our CBP personnel and make sure they're better trained to do those kinds of assessments, because I just don't think it's feasible to put licensed medical personnel down there. I also want to say that I agree with Dr. Danaher that the pediatric cuff, the pulse ox would have been helpful at those border facilities. But as an emergency physician, I can tell you that when Jacqueline was posturing, it would not have made a difference in this case. And to say so is a little bit misleading. also as a doctor, I've provided care from Zawai, Ethiopia to the Himalayan, and a good field medic doesn't need a BP cuff to get a decent pressure off of where you take the pulses. Dr. Mitchell, I wanted to ask you, what areas of the hospital, what areas of hospital care and care of a patient do you recognize as the highest risk for medical errors?
Well, in my experience, I've seen medical errors in the surgical suite. I've seen medical errors in the ICU. I've seen medical errors upon presentation. We talked about the poor intubation of one of our patients. So, where medications are prescribed and infused, you can see medical errors. So there's several places within the system where you can see them.
Well, JCAHO has done some pretty extensive research in this. Obviously, the Joint Commission on Hospital Organizations, they're the folks that accredit our hospitals for those who aren't medical providers in the room. They've done a lot of research on this, and those transitions of care are fraught with risk. When one provider hands a patient off to another provider, going from the emergency department to the ICU, shift change is an incredibly high risk time. And the gentleman from Louisiana mentioned that pickup time when one of the officers was going off shift with Felipe particularly, and another came on, gassed his car up, got there a few minutes late. But when he got there, if you'll recall from the testimony, tell us what that officer did and how he responded when he discovered the severity of the situation with Felipe.
Well, I think the Border Patrol agents acted swiftly to engage the patient and try to get the patient to care, and that was evident throughout the record that I reviewed.
Do you think there was anything else they could have done?
No. I think the agents are acting, particularly in Felipe's case, and quite frankly in Jacqueline's case, these agents, when they became aware, they moved to make sure that those individual patients got to care. And so, they, I don't think, probably are as equipped to recognize the things that they needed to recognize. And so we talk about that training. We talk about making sure that we have adequate personnel that is doing that work and not putting it on agents whose job it is to protect in a different way the border. But yeah, I think the actions were swift and accurate.
Thank you, Mr. Chairman. I think my time is up.